Thank you to our panel. A special thank you to Dr. Ackerman for also sharing the personal nature and the personal perspective of her story. Our next speaker is Dr. Robert Cothren, who is Executive Director at the California Association of Health Information Exchanges, where he leads a diverse group of stakeholders in realizing statewide interoperability in California through outreach, education, policy development, and emerging technologies that enable and promote widespread, secure sharing of health information. Here to talk about 21st century cures and the creation of a national health provider directory, please welcome Dr. Cothren.
Thank you. Can we rewind that to the first slide? Yeah, I'm here. I'm going to talk about infrastructure for a little bit. I'm sure that that's really exciting to everybody. When Jeff asked me to come talk about directories, I was happy to. Jeff and I share a passion for directories, been working on them for a long time. Maybe that's a twisted passion. I don't know for sure. But Jeff and I are also different in one very important way. Jeff has an operational directory that's sustainable, very functional, and does a lot of work. I just built my third. And looking at the silver lining on everything, I'd like to think that you, and I continue to tell myself, that you learn more from your failures than you do your successes. So I must be very wise. We've been sharing stories today. And I am acutely aware of the fact that we're running a little bit behind and I stand between you and lunch. So I'm going to keep this very short. We talked a little bit about comfort and information sharing, and I thought it was necessary to talk about that for just a second. And it's not the typical story. You know, my wife still gets the call from her shoulder surgeon saying, would you please stop by radiology and pick up your films before you show up at your appointment this afternoon? And she turns to me and says, can you tell me again what you do for a living? It's a different story. Today would be my father's birthday. He died of a heart attack on Mother's Day last year. And my story is also not about his death. He received excellent care. Things happen. Sometimes people die. It was two failures in the healthcare system that became really clear to me later on that same day. And I was at my mother's house and going through his paperwork to try to get things in order following his death. And I came across his POLST form. And I'm sure a lot of people in the room know about what POLST is, physician's orders for life-sustaining treatment. It is a gosh awful pink piece of paper in California, probably ugly in most states, that are actionable orders signed by a physician that help ensure that a patient's wishes are met late in their life. I was horrified. My father shouldn't have a POLST form. He's elderly, but otherwise healthy, has hypertension or had hypertension under good control, fell occasionally because he had weak knees, but had nothing else going on. And there on the form was the box checked that said, in case of cardiac arrest, I want no life-sustaining treatment. And that, of course, wasn't what he wanted. And later, talking to my mother, came to understand, well, she had one too. And it said the same thing, and she's likewise healthy for someone her age. And well, if I were dying of cancer and my heart stopped, I wouldn't want somebody to do something. I'd rather they just let me die. But you don't have cancer. And the truth is that my father shouldn't have had a POLST form. That was the first failure, is that I'm sure that in talking to their physician and saying, I want one of these, and this is what I want, he signed the form, sent it home with them, knowing that it would go into a ring binder, which is exactly where it was, and it was safe there, and that right decisions would be made. The second failure was that they did not discover his POLST form. Now, California is working on two projects that I think are really important. One is to make sure that EMTs can actually get health information about somebody when they're in the field and learn more about them. And the second is to provide an electronic registry for POLST forms. Well, if we'd done our job and we'd been successful, the EMTs might have discovered his form and might not have tried to save his life. So when you ask questions about whether we're comfortable with what we're doing and trying to make information flow, well, yes, I'm very comfortable with what we're doing, but I think that we need to continue to remind ourselves that we're causing profound changes in the healthcare system, and that those profound changes will have consequences on how medicine is practiced. I think ultimately all of them good, but that we need to be aware that we're not just informing people better, but that there are times when we become very comfortable with the lack of flow of information, and we need to be aware of that as well. I'm going to continue to be passionate about making sure that information moves around, but I think that we do need to be aware of the consequences of getting that information moving and make sure that we deal with those issues as well. All right, so let's get started here. I'm going to talk very briefly about directories today. We'll start off by talking about why we're bothering to talk about them at all, and why Jeff and I continue to be passionate about them. The how you might be able to produce interoperable directories and what some of the challenges are there, what some of the people are doing today, just a very quick review, and I'm not going to be exhaustive in that, but then the meat is that final, when might we get to a national directory and what's going on to try to get us there. I'm going to expose the fact that I'm paranoid about being a contractor and consultant for a second here. People that are part of the ONC project in provider directories and healthcare directories know that I do some work for ONC, and I'm not speaking for ONC today. I'm just another volunteer that's passionate about this topic. And in fact, everything that I'm going to say about what's going on at ONC, anybody in the room could discover this if you were part of that project, and I encourage you to be. First, we'll talk a little bit about why it is that we care about healthcare directories. And the first, from the standpoint of somebody that does interoperability and exchange, HIT is just a mess today. And I think that we all understand that in order to make information move, you need to understand the identities, the providers, and the provider organizations that are going to be the recipients or the senders of that information. You need to understand where they can be reached, what affiliations they have with organizations, what affiliations they have with plans, et cetera, and that's a lot of information that's not well known. And so it's important for us to actually gather that information and know definitively what's going on with it. If I get a little bit more personal and talk about it either from a patient standpoint or from a provider's standpoint, you can see that there are a lot of failures here. You know, just as a patient, if I'm trying to find a primary care physician for myself, well, what do I do? Well, my plan publishes a list. Might be right, probably isn't. So I'm probably calling people to see, well, are you actually taking patients? This list says you are, and you're now the third person that's told me that you're not. As my doctor, and you're searching for somebody to send me to as a specialist, well, what do you do? Well, you know, the list of specialists that somebody works with is probably in their head. It's not someplace else, and it's the people that they always send people to. And how do they know that they accept my insurance? Well, they don't. So, you know, there's a lot of hope there about, well, I hope that that's okay. And can you tell me, you know, who you know might be on your plan? I was struck by seeing my PCP about a skin condition and needing to go see a dermatologist. And his question to me was, well, do you know a dermatologist you'd like to see? Well, no. I wouldn't have come seeing you if I had a dermatologist already. And so, you know, there isn't a good path there. How do I send patient information to a physician? You know, somebody else that's treating this physician. Well, solutions often Post-it notes. I mean, almost no joke that, you know, it's the direct address I have because I called this person and asked what it was. You know, I don't have a good source for that information. How do I get information from a colleague? Well, I just hope, because there's nothing that's going to necessarily enable them to get there. And how do I, as a patient, get my own information? Well, we'll talk about that a little bit tomorrow, but we're not going to get there today because we're just starting to scratch the surface there. I'm not going to try to pretend that I understand the Cures Act and that I've read the whole thing. So I borrowed a quote from someplace else that I could find out on the web, but the Cures Act does call for electronic provider directories. And so there is some prompting that there really will be a national solution here. What I'm going to talk to you about, though, is something that began before the Cures Act came out, and it's already in flight. And so this will probably just be additional motivation later on. So let's just talk real briefly about standards for a second. I have to do this. I'm a technologist, so I just can't not. There are really two standards that people usually talk about when they're talking about directories. Healthcare Provider Directories, or HPD, is the most common one, and people can't help but talk about FHIR. Well, the truth is that they're bracketed by two other standards that don't get much airplay that we'll talk about just very briefly as well. The first is UDI, or I don't know how to pronounce it for sure. It was intended to be the white pages to the World Wide Web, and it was how you in general would automatically discover how you would find web services out on the internet. Well, doesn't that sound about right? Well, unfortunately, UDI directories have largely failed. It was intended to be the white pages, but the white pages doesn't exist. And in fact, as a standard, it is no longer managed or developed. So it's effectively a dead standard here. And that's despite the fact that it's in use today by the eHealth Exchange as the only solution that was available at the time of putting things together. And we'll talk later about the fact that the Sequoia project is even moving away from using UDI as their solution moving forward. Healthcare Provider Directories, or HPD, was the standard that I first implemented. It was specifically designed to talk about individual providers, their organizations, relationships, the way to communicate with them. It sounds like the right pile of data here. Unfortunately, it's based on Web Services XML-based standard that implies an underlying LDAP directory structure. Well, LDAP isn't a problem. There are good, successful LDAP directories. But the standard is pronounced dismal, and that should have been prophetic. It's a terrible standard to work with, and it has been a failed implementation, a failed standard because nobody wanted to adopt the interoperability there. Good data structure, and I think a lot of us still look to HPD as a mechanism for us to understand what data needs to be maintained, but a terrible API. So there's strike two. CSD is actually a really interesting standard. The problem with CSD is not that it is not capable or not well implemented, but it's not adopted. I don't know of a single implementation of CSD in the US. It is implemented in some cases abroad. So there's really our third strike, that 3 of the 4 standards were not in very good shape. So we'll turn to FHIR for a second. Now, FHIR is getting a lot of hype these days, and I think that's probably the problem with it. FHIR is intended to describe all of healthcare, including providers, provider organizations, relationships, care services, a lot of information that you can get out of FHIR. And it uses more modern RESTful APIs, so it's kind of headed down the right path. Unfortunately, there is a huge amount of hype around FHIR, and I would claim that FHIR is not yet ready for prime time. And you know, you don't get 4 strikes, so I didn't put a 4th strike here. I think that FHIR will get us there, but it's not there yet. And I think that we shouldn't kid ourselves about that. Despite the issues with the standards, and those are going to be some of the challenges, there are other challenges that are really serious here as well, and that's that the data needs to be accurate. You know, we're going to be making decisions on disclosure of PHI based on information that we find in a directory. And it's hard to verify that information, even if it's as simple as a practice address or a phone number or a fax number. It's extremely difficult to verify, and especially difficult given that that type of information changes on a regular basis as providers change their affiliations with larger provider organizations. So it's just a hard area to be. So let's talk just real briefly about what people are doing in this area today, because I think it'll set some context for what's going on at ONC that might lead to a national directory. So One of them that I'm sure most people know about is NPES, National Registry for NPIs. It's really, it was mandated under HIPAA, and a lot of people don't know that, but is really targeted not at being a directory for provider information, but as the registry for NPIs. But a lot of people think of it as a provider directory because of what it does. It recently has had an API added to it, so you can actually extract information out of NPES. Most people use it by taking dumps of the entire directory and dealing with it themselves. But it has real issues with the accuracy of the information in it. And part of that just stems from the fact that there's no real motivation for providers to keep that information up to date. In fact, there are a lot of providers that put in information when they graduated and were licensed and applied for an NPI and haven't touched it since that time. And it's quite likely that the information that's there is no longer accurate. So if we talk about motivation, there's an interesting thing that happened out in California that I often point to. SB 137 is a piece of legislation that acknowledged and tried to address the fact that provider directories and plans are really bad. It's the result of some secret shopper initiative, just looking at provider lists on plans, calling up those providers and asking whether they were actually participating in that plan, and found that somewhere south of 60% of the time, the directory was right. And that was a real problem. So the legislation carries real teeth with it. It mandates that the plans in California create an accurate directory and publish it both on paper and electronically on a regular basis, and that it had better be right. And if it's not right, for example, if I as a patient get care from an individual believing that they are participating in a plan and that's wrong, well, the plan has to pay their fees anyway. And they get fined for the inaccuracy on top of that. So it carries some real teeth to it. And so there's interest not just within the provider community or the interoperability community, but also within the plan community for trying to make things work. A lot of people are probably aware of the Direct Trust initiative to distribute information about direct addresses on individuals. And there's a huge amount of participation. I'm sure the numbers up here are wrong. Every time you talk to the folks, there's another organizations participating and more addresses being issued. However, this is still an Excel spreadsheet that is passed around with really information about direct addresses on individuals. And while it's an important step forward to try to start distributing information, it's not going to address all of our problems yet. It also took an important step in starting to wrap policy around the sharing of this information. There is a data sharing agreement that's been created for sharing information here, and an acknowledgement that data governance, that data quality and data sharing need to surround directories as well, that I think is important for us to latch on to. And then, as I said before, the Sequoia project is moving away from UDI and has recently gone live with a FHIR implementation based on extensions to the recent STU3 version of FHIR around provider directories. And they found some shortcomings in it that they went ahead and extended it to include some additional information about the use cases, version number on APIs, et cetera, that were used there, that again starts to move us one step forward in something that happens on a national scale. I would say that probably the most interesting work, however, is happening more at the state level. And I'm not going to presume to explain what's going on in Michigan, because it is still one of the coolest directories around, and the capabilities there really are a model for where we ought to be. But I think some of the important things to remember is that we're really talking about not only individual information, but organizational information, association of those individuals with organizations, eventually association of individuals and organizations with the patients, in order to address many more use cases than just the exchange of information. And that's really what the goal should be. Okay, so let's finally talk about what I actually stood up here to talk about. And that's the Health Care Directory initiative that's going on at ONC. And the scope of this, first of all, was about provider directories. It was about healthcare directories and not provider directories. It was an acknowledgement that we're talking about a larger scope than just describing the phone numbers and direct addresses of individuals, but we needed to be talking about a lot more. And the intent was to form the creation of a national resource, and I would like people to think about it as a pile of data, not a replacement for a local directory, and so not a replacement for what is already working here in the state or even what I built for the third time in California. But a vetted information that's been verified and known to be accurate through processes that are discoverable. And the method that they're using is to really build on the experience of a bunch of volunteers. And some of those volunteers are here in the room. Jeff has been instrumental in this. Carol, that I've seen here, is. I am. I would imagine a number of the other people in the room are aware of this and are participating in the process. It is sponsored by ONC and FHA, and it really, as I said, is based on the work of volunteers through work groups that they call Tiger Teams, really in 4 different areas: in identifying use cases, the data elements that support those use cases, and architecture that that can be used to distribute that information, and interoperability standards about how that information would be exchanged. And they engage the broader community through something that they call the technology learning community. That's, I kind of think about COP, but it's not really a community of practice. I checked yesterday, there are almost 400 people that have signed up. Normally their meetings have somewhere between 80 and 100 people that are participating in them. And I would really encourage people that are interested in understanding what's going on at the national level to participate in the HcDir TLC, if that isn't a confusing enough set of acronyms. As I said, it really operates through a number of Tiger Teams. The use case Tiger Team informs the data elements Tiger Team on the data that is necessary in order to solve this problem, and the data elements Tiger Team passes those recommendations on to the interoperability Tiger Team so that they can understand what information needs to be transmitted between directories, and do that being informed by the architecture Tiger Team. Again, the ultimate result of this should be a national standard and architecture and a pile of data that's been vetted that has engaged HL7 as its standards organization. And so not just an ONC project, but something that actually happens on the national scale. I'm going to run through a number of things associated with the effort here very quickly, and I would encourage people to go out and learn more if they're interested. First of all, there are a number of different use cases, and I think I'm not going to read through them all here, but I think what's interesting here is what you don't see is a use case that is the exchange of information. Sure, that's the first one, but there are a whole bunch of others too, and that really reflects the larger scope in this effort, that we want to not only describe individuals and their phone numbers and their fax numbers and their practice addresses and their direct addresses and other ways to exchange information with them, but we want to be able to make sure that we describe their relationship with other organizations, that their relationship with each other in a patient context that might describe a care team, that their relationship with plans, the products that they participate in with those plans or the networks that they participate in, and even goes so far as to make sure that it addresses some of the issues associated with payment, et cetera. To give you an idea of how far-reaching the discussions have been, is we've talked about whether the directory is a place to include consent information about the sharing of information. We declared that to be out of scope, but those are the types of discussions we're having. But what is in scope is whether organizations are participating in some of the trust networks, trust frameworks or trust networks such as Direct Trust or the eHealth Exchange or Care Equality or Commonwealth that help to facilitate exchange, and that likely will be part of the directory. If you go then into the data elements, this group is working at the data definitions, the the cardinality requirements for information in the directory, and the code sets that are used to describe it. One of the big failures of a lot of standards is that, yes, it'll say that gender is there, but how do I represent gender will be largely unspecified or insufficiently specified. Now you talk about specialty and it becomes much more difficult. HPD, for instance, specialty is a text field, full stop. So that is not interoperable. The data elements team is going through a much more detailed analysis driven by the use cases and the requirements of information. There's a snippet of one of the spreadsheets that's actually posted out on the data sharing site to give you an idea of the pile of data that's there. For instance, if you look on the Excel spreadsheet, the area on credentialing alone takes up a full page on my screen. And so it's a huge amount of information that people are combing through and trying to understand what needs to be in a directory to make all of this work. From an architecture standpoint, again, this initiative is not meant to be a national directory, but a national resource of vetted information that can be used to deal with use cases across the continuum. But it does, the architecture team, therefore, is not producing an architecture for a national directory, but an architecture that describes how you access this information, what use cases need to be supported there, how various actors interact with each other, and including discussing some of the cases where information perhaps should not be shared, where, do you share the street address for some clinics and perhaps enable actions against them. So it's an interesting group to be engaged with. And then from an interface standpoint, the decision has been made to go with FHIR, despite the fact that it perhaps should have gotten strike 4, because industry has really begun to embrace FHIR already. And that means that the goal here is to produce an implementation guide on how FHIR will be used to address this great big problem, including extensions, code sets, et cetera, really constraining and adding on to that standard. A lot of us are watching that and planning on making changes to our own implementations as that emerges. So I did want to reserve at least a little time for questions, so I'm going to try to wrap up here quickly. If people are interested in learning more about this, there is some public information that you can get to easily. However, you do need to be part of the group in order to get access to the data sharing site. There's one email list that I've listed here that you can get a hold of. You can also send an email to me if you want to participate, or Jeff. Anybody that is part of the group can invite other people to be part of it. And as I said, there are about 400 people that are signed up on the site right now. So it's very easy to get access to more information. So we've talked a little bit about the purpose of healthcare directories and some about the scope of what we're talking about. We talked a little bit about standards and some of the challenges associated with them, a little bit about what's going on now. And again, I'd say that far from exhaustive, but at least a few examples there. And I'm hoping for what the future might bring in a national directory, a national resource for us to work with. Now, you saw that half of my talk was talking about cures, supposedly, and I haven't touched on cures very much. And I think that's fine, because as I said before, this initiative started before the Cures Act began, but I think that the Cures Act will help ensure that we actually do move forward with a national resource, and so I really do encourage people to continue to pay attention. Few things that I'd like for people to take away. This really is hard. We're not talking about just a phone book. And the good thing is that I think a lot of people are working on it, a lot of smart people working very hard, twisted but passionate about it. The future is not particularly certain right now, but I still think it's bright. I think that we're going to get there, because I think that this time we've got the right people working on it, we've got the motivation, and I think that our industry in general has matured to the point that we're ready for something like this. So thank you very much, and I think we have at least a few minutes left over for questions before we send you off for lunch. Thank you. Are there any questions? So I try to keep myself out of trouble in this talk, but now that Jeff is standing up, I know that...
Going to really zing you now
yeah,
because you gave
yeah.
me so many kudos. Thanks, Rim. I was wondering if you could touch on the multi-stakeholder nature of, the very wide variety of types of individuals and organizations that we had in the Tiger teams and so forth.
Good question, Jeff, and thanks for bringing that up. There were representatives from what you would consider the major federal agencies that are involved in exchanging PHI, from state initiatives. There were vendors involved, members of the standards development community, consultants like me. There were providers represented. There were plans very much engaged. There were service providers that offer products in this area. Really, the idea here was to engage the entire community and build upon the experience that was out there. So it really was an expansive group of folks. One of the things that I will mention somewhat associated with that is when we talked about data elements, we were talking about how do you verify this information, and there you're talking about data governance and getting all of those stakeholders engaged and involved, and part of that process was important as well.
Okay, real quick, we have probably time for one more to make sure everybody gets to lunch on time.
Hi, I just wondered if there was a succinct list that this group could digest of what sort of issues you ran into with fire, things that we should be aware of as we look in the future towards the use of fire.
Sure. I will do this off the top of my head, at least to get started, and I'm probably going to miss something important. There are going to be other people that have used fire as well, and I'm sure that they're going to have their own lists. I don't have a problem with the idea of using a RESTful API that transfers JSON and XML documents. I think that that's a very reasonable way to deal with, and I'm a big proponent of granular information. I have been from day one of interoperability, so I think that it's headed in the right direction. The issues with fire is that it hasn't been used very much. We have now said that we've put out version 3, and it appears in very few commercial products, so it hasn't seen a lot of airtime. Those of us that have implemented it find that we need to extend it. It has mechanisms for extensions, but that just points out that it isn't all-inclusive of all of the things that need to be in it. It is still changing on a regular basis, so it's not a stable standard yet. And I think one of my biggest concerns with it is that the code sets associated with data elements in FHIR are really insufficient, at least in the directory area, to address the things that we need it to address. And so as anybody here knows, if you're really going to be dealing with interoperability, you need to understand what terms and terminologies you're using for data elements, and FHIR is just not mature enough there and not inclusive enough of all of the things that we're trying to do. One of the big efforts associated with the ONC initiative is to define the code sets that are going to be used and ingrain those through the standards development process with HL7. So it won't just be a one-off, I'll post it on my website, what I use, but something that becomes part of the standard.
So
Right.
similar to, yep. Thank you, everyone. Thank you to Dr.
Thank you.
Cothren.